Okay, I'd like to go ahead and welcome everybody back to our second panel of the day. So our next panel will be on exploring sustainability funding for trauma care and systems. And I would like to note that we now have a more stable way for our speakers and panelists to enter. So yay for safety. So at this time, then, I'd like to go ahead and welcome our moderator, Alex Mays. Alex is the Senior National Program Director with the Healthy Schools Campaign, a Chicago-based nonprofit with a mission to advocate for policies and programs that allow all students and staff to learn and work in a healthy school environment. Alex leads her organization's work to increase access to school health services through Medicaid reimbursement, working with states and school districts across the country to expand school Medicaid programs. She also oversees the Healthy School Campaign's efforts to support student health and school wellness through implementation of the Every Student Succeeds Act. And Alex received her BA in Neuroscience from Pomona College and her Master of Health Science from Johns Hopkins Bloomberg School of Public Health. So welcome, Alex. I'll let you introduce your panel.
Thank you so much for the introduction. Again, my name is Alex Mays. I'm thrilled to be here. My organization is called Healthy Schools Campaign, and we've had the pleasure of working with Kaiser, Alliance for a Healthier Generation, and then Center for School Mental Health to help do some of the planning around today. So it's great to finally be here and have the day here. And I want to thank you all for taking the time out of your busy schedules to join us. So we are, for the next hour, going to be digging into a question that I'm sure many of us have been asking throughout the morning as we've been hearing about all these fantastic programs and ideas for how we can address trauma. There's always the question of, well, how can we fund it? And how can we do this in a sustainable way that really enables communities to be accessing the resources that they need to be implementing what we know works and implementing these evidence-based interventions. And so that's really what we want to be digging into over the next hour. At Healthy Schools Campaign, all of our work is centered around that idea that healthier students are better learners and that all students should have the opportunity to learn in a safe and healthy and supportive school environment. And really core to our work is looking at how we can change the systems and the policies to really make health and wellness an integral part of the school day. And so for our panel today, what we're really going to be digging into is, again, those sustainable sources of funding, and looking at ways in which, certainly that we can access grant funding opportunities, but also how we can really look at some of more sustainable funding mechanisms to support this work. How can we change state policies around Medicaid, around education, to bring in dollars that can be utilized by communities to address trauma in schools? As we've heard throughout the day, I think this is just such an exciting time to be having these conversations. Certainly there's tremendous attention and interest around trauma and increased awareness of the significant impact that it's having both on kids' health and learning. There's also some really exciting opportunities to make a lot of those changes in systems and policies to bring in the funding to support this work. Just as a couple examples on the education side, there's a new education law called the Every Student Succeeds Act. I don't know how many people have heard of. Great, that is wonderful to see. And so the Every Student Succeeds Act replaced No Child Left Behind about 4 years ago and really just included a much greater focus around the whole child and a recognition of the need to do so much of what we've been talking about today, and gives an incredible amount of flexibility to states to really think about how they can be delivering professional development programming that not only trains teachers and school staff around how to meet the core academic needs of their students, but also how to connect them with mental health supports within their community, how to be creating trauma-informed schools, how to be ensuring that students are feeling safe and supportive throughout the school day. And that new law also comes with a number of funding opportunities to really dig in and support that work. And then on health and public health side, we'll really dig into this today. There are numerous opportunities within Medicaid that states and communities can really be leveraging, as well as other pots of funding to move this work forward, which include not only expanding Medicaid to broader populations, but also really ensuring that states are covering and supporting a full range of screening, assessment, and treatment services. So we're very fortunate to have an expert panel with us today that's going to dig into a lot more of those opportunities and lift up some of those concrete ways in which you can think about funding this work in a sustainable way. A lot of the opportunities that are going to be highlighted are really at the state level, and so just something to really think about as you're listening is questions that you can be bringing back to your state to better understand if your state is leveraging these opportunities, and to think about, how they might be trickling down if you're at the school level to your school or district. So today, again, we have a fantastic panel with us. I'll quickly introduce each of the speakers, and then they'll say a little bit more about themselves and their organizations when they get up here. We're joined by Shadi Houshyar, who is an associate with the Center for Study of Social Policy, and then Alice Lamb, who is a director with Manatt Health Strategies, and then Sarah Mathew, who is the director of the Office of Health and Wellness with the Colorado Department of Education. Shadi and Alice are really going to provide additional details about opportunities within the health sector to prevent and mitigate the effects of trauma. And then Sarah's going to dig in more around some of the work that they've been doing in Colorado to really look at funding this work and doing it in a way that braids together a lot of different funding streams. And so I'll hand it over to Shadi, and then we'll be sure, just as we did with the previous panel, to save time at the end for questions and answers. So, Shadi.
Hi, everyone. Can you hear me okay? Yes. Okay. Great to be here today. I'm excited for this conversation. When I was told I had 10 minutes, I said, okay, I think I can do that. We'll see. We'll try our best. I might have to go really fast. So my name is Shadi Houshyar. I'm a senior associate with the Center for the Study of Social Policy in Washington, D.C. In our work, we're really focused on advancing policies and ideas to help us achieve a racially, socially, and economically just society where all children and families can thrive. So we have already heard a lot about ACEs, and you all are also, I'm sure, very familiar with ACEs. So I'll just go really quickly to some of the key points that I just wanted to highlight when we talk about ACEs. We now understand that ACEs influence health and well-being, and we recognize the mechanisms by which they influence health. Our understanding of ACEs, though, has evolved over time to really also recognize the role of historical trauma and systemic and institutional inequities that really compound and create trauma for families. So that's an important add-on, I think, to our understanding that has evolved over time. And I should say that many of these structures are often punitive and embedded in racial bias. They limit opportunities and come with built-in economic and social inequities. And while we won't have time to really delve deeper into these issues, an equity frame on ACEs is very much at the heart of how we at CSSB think about and do this work. I'm happy to talk to you about that if you're interested. So again, I won't get too much into detail. We know that ACEs are common. They're highly interrelated. They happen in a strong and graded fashion. Again, something I want to point out is that ACEs are far more concentrated and prevalent in communities that are struggling with poverty, economic hardship, community or neighborhood violence. And these experiences are often driven by deeply entrenched, again, historic, systemic, and institutional inequities that increase the risk for poor health and limit resources available to promote good health or improve health. So that we see that even at higher income levels, children of color continue to experience disproportionately higher levels of ACEs to white children of the same income levels. We also see that low-income children and children of color are also less likely to receive the services and supports they need to mitigate the effects of ACEs. And these inequities, again, are a result of generations of government policies favoring some communities over others and are some of the factors at the heart of and fuel for ACEs. So this is really important, and we've heard a lot about it this morning, so I'm just going to build on it. ACEs have helped us understand risks, But risk factors are not predictive factors because of protective factors. ACEs do not destine a child to poor outcomes. When children who are at risk of or who have been exposed to ACEs can access a broad array of services and supports, from safe, stable, nurturing families to access to healthy nutrition, stable housing, safe communities, early care and education opportunities, and high-quality schools, they develop powerful resiliency and the ability to achieve a healthy, independent, and productive life. So one key protective factor that we've heard about, and I just want to say again, is the presence of supportive relationships. Supportive relationships offer protection from the effects of stress. And when we think about ACEs, it's really important to remember the powerful buffering effects of protective factors, including relationships. So when you think about ACEs, you have to think about protective factors. When you screen for ACEs, you have to think about screening for strength-based and protective factors for families. So a key strategy for supporting children and families is to provide services where families spend time. This includes the home, schools, early care settings, and healthcare. The majority of young children are seen regularly from birth into the early years in pediatric settings. So healthcare is really well positioned to address ACEs, given that it is a nearly universal system. It's also important to note that federally qualified health centers serve 25 million people annually and are present in the poorest, most disinvested neighborhoods. So there's another opportunity to really think about leveraging healthcare. Healthcare is also becoming more attuned to addressing the social determinants of health. We heard about this morning. These are factors outside of healthcare that impact our health, like housing, nutrition, our schools, our neighborhoods, and our communities. We now recognize that healthcare health happens outside of healthcare, and it really is about more than what happens inside the clinic walls and more in our life. So as a result, healthcare delivery transformation is also now focused more on these social determinants of health that drive more than 80% of the variation in health outcomes. So although I have a much broader set of recommendations that I'd love to share with you on how to leverage health systems to address ACEs, I wanted to share a few key opportunities with you here. Among them is a recommendation for federal and state policymakers to increase access to comprehensive, affordable health care for children, families, and communities by strengthening and protecting Medicaid and CHIP. A few of the specific opportunities are taking up Medicaid expansion in states that haven't. Parent coverage is incredibly important for children's social and emotional development. When parents have the health care they need, their children are more likely to have their own physical and emotional and behavioral health needs met. At least 37 states and D.C. have taken up Medicaid expansion, meaning a larger portion of low-income parents now have health coverage. Even so, some states are pulling back. We're seeing work requirements, premiums, and other policies that are going back in the opposite direction. So states should be really focused on reducing barriers to coverage, not creating them. Medicaid and CHIP provide health coverage to close to half of children under 3, and states currently have the opportunity to provide 12 months of continuous eligibility coverage to children in Medicaid and CHIP, allowing them to remain enrolled for a year regardless of changes in their income and family size. And I think about half of states have adopted this option. What I think would be incredibly important is 5 years of continuous eligibility that could significantly improve the health and well-being of young children. We're now seeing drops in children's coverage, and we're really concerned about this. One thing that could really improve it is continuous eligibility that would go up to 5 years. And last, states currently provide postpartum coverage for mothers for 60 days. This should be extended to a full year postpartum. It's incredibly important for both mothers and children. So another recommendation for federal and state policymakers is to really invest in and scale home visiting programs. Home visiting builds on decades of research. It provides individually tailored support to families in their homes, and it's really about promoting parent-child attachment and positive parenting. It yields positive outcomes. We have decades of research on this, on maternal and child health, on reductions in child abuse and neglect. Nationwide, 18.3 million families have a child under 6 or on the way who could benefit from home visiting, and yet evidence-based models reach about 3%. And states use a variety of federal and state dollars to support home visiting, patching it together, but scaling home visiting will require a real expansion of federal funding. So in addition to expanded funding from McV, we should be thinking about Medicaid and other opportunities to really scale home visiting. A recommendation for leadership in child and family serving agencies is to promote stronger collaboration across agencies that serve children and families. There's a number of different ways to do this. You could be using data sharing agreements between Medicaid and agencies that include early intervention and child welfare, thinking about a single cabinet or appointing a children's cabinet or a governor's initiative that focuses on children's needs. I think I'm behind one. There we go. You guys might have been wondering. Okay, so a key recommendation for state Medicaid agencies is to expand financial support for community health workers to coordinate care in pediatric health and other settings. Community health workers are an important opportunity to improve health outcomes while reducing healthcare costs. Integrating individuals like social workers, community health workers, and promotores. These are individuals, community members with lived experience who receive training to provide basic health education, screen for and connect families to resources, and really serve as a support for the family and a physician extender, are known to really extend the reach of pediatric providers and deepen trust with families. If states don't already authorize Medicaid coverage for expanded care team members, they can amend the state plan to do this. There's a number of ways to do it. States also have flexibility under Medicaid to allow care to be provided in home and community-based settings. These are settings including early care and education programs, family resource centers, WIC clinics, and other places where young children spend time. So a recommendation for state Medicaid agencies is to allow pediatric health providers to bill for maternal depression screening and cover treatment under a child's Medicaid benefit. Conducting maternal depression screening in a well-child visit is really an opportunity for new mothers, as many as half of whom do not get their own postpartum visit to discuss their concerns and receive treatment. As of 2018, 32 states allowed maternal depression screening to be billed under a child's Medicaid. This is a huge opportunity for states. A recommendation for health systems and really all child and family serving agencies is to partner with families at all levels, including policy development, program design, and implementation. We know that family-centered care and shared decision-making contribute to better outcomes for families, better quality, and patient safety. Yet barriers that are rooted in structural racism and biases that influence attitudes, behaviors, policies, and practices of child and family serving agencies prevent many families and many families of color from being true partners and leaders in their children's healthy development. There's a number of ways health systems can partner with families, creating opportunities for shared decision-making, pursuing community-based participatory research, partnering with and investing in parent and community-based organizations to support their ideas. We at CSSP have a working group of parent leaders across the country that are really thinking about these opportunities. We have a manifesto on how to do this in early childhood systems that can translate to other systems, and I'm happy to talk to you if you're interested in that. Another recommendation for health systems is to use an institutional analysis to identify and mitigate the health harms of institutional racism. So in healthcare, institutional racism affects coverage, access, delivery, and other dimensions of care that results in higher disease rates and worse outcomes for minority populations. And so IA, what it does is it identifies the standardized institutional methods like administration requirements, job descriptions, employee training, and policies that may compound or produce poor results, and really pinpoints those inherent organizational policies and practices, the underlying structural barriers that contribute to inequities for families. One potential opportunity for health systems is to use the hospital community benefit or the community health needs assessment to implement and support institutional analysis. A key recommendation for primary care providers, I don't have any time, is to promote population health by better connecting and integrating healthcare and social supports. There's a number of models that are using this in pediatrics, including Project Dulce, which we at CSSP implement, that really is about embedding a care coordinator plus into the well-child visit for babies 0 to 6 months and their families, screening for social determinants of health, screening for maternal depression, interpersonal violence, connecting families to services and supports and opportunities that they need. And these models have been effective in improving access to concrete supports, reducing emergency room visits, improving compliance with well-child visits. And the last one is we need to target interventions to young children ages birth to 3 and their caregivers. And we can do this in the pediatric setting. We have multi-generational approaches that really work. They demonstrate effectiveness in improving parent-child relationships and mitigating ACEs. And programs are doing this, things like centering parenting, which is a well-child model where you bring groups of parents and children together for well-child visits. Project Dulce, which I mentioned, Healthy Steps. There's a number of these models that need to be scaled. And I didn't talk about financing, but I think my colleagues will. But one thing I want to say about financing specifically is that half of U.S. children and 2/3 of those with public health insurance have been exposed to ACEs with lifelong consequences. This is an opportunity to leverage our health system to support young children and families, but our current financing doesn't adequately invest in social determinants of health. And so we need to look at what high-value care looks like for children. And it looks like health promotion, prevention, early identification, effective linkages to services, supports, and opportunities, family-centered care, coordinations of systems of care. But we have problems with that because children are not a high-cost population, and a lot of the benefits that we see accrue over the longer term and sometimes to other systems. So we really need to define what high-value care looks like for children and put prevention and equity at the center of that. Thank you.
Hi, good afternoon, everyone. Can everyone hear me okay? Yes. Okay, great. Well, thanks, Shadi, for that. Actually, it was a good segue then into financing strategies, because my name is Alice Lamb. I'm a director with Manatt Health Strategies, and I'm here to talk about just making the case for leveraging Medicaid and the Children's Health Insurance Program for financing a variety of interventions addressing social and emotional health and development for young children. And it's actually keying off of a project that I'm currently engaged in, actually with some of Shadi's colleagues at CSSP, and we've developed a resource coming out of that will be included in the conference materials. But I think that will really help, since the conversation a lot is to deal with state policies and leveraging state policies, but be able to give, for folks in the room here, a tool and a set of references to be able to use in your conversations with state policymakers to actually be able to kind of advance these different changes. So a little bit about Manatt and the work that I do, which is actually really focused on working with state Medicaid and CHIP agencies. A lot of my day-to-day is working with those state officials to figure out what are those policy opportunities, what policy changes need to be made to actually effectuate and meet their program goals, and to help them also think about implementation. I also do a fair amount of work with community-based organizations, Medicaid, delivery systems, and health plans, similarly thinking about Medicaid and CHIP opportunities, which is why it's really exciting for me to be able to talk to this audience about, so how do we kind of marry all of these things together, and how do we really focus on leveraging these different opportunities. So if I can leave you just with two things today, which I hope we'll be able to get through as I move through my presentation. I think it's one, while Medicaid and the Children's Health Insurance Program are complicated programs, there are multiple opportunities to be able to support interventions addressing children and families and social and emotional development and health. And that the second is that we're really seeing this as a very special time and for attention and focus on better supporting our children and their families. There's been a real groundswell of activity in the last several years, and interest, and finally some federal and state policy alignment also in terms of the focus. And we're really also observing state appetite in terms of really thinking kind of beyond the bounds of health. You've heard mention of social determinants and the importance of social factors. I think there's really that growing recognition and interest at the state level and thinking more cohesively about the different types of opportunities that might be out there, and states that are really pushing the bounds on that as well. And I'll go into that a little bit more later, but I think that's why it's really an important time to be capitalizing on these different opportunities. So what you see on the right here, though, is just that the work that I've been doing has been under this umbrella of pediatric supporting parents. It has been generously funded by several foundations, and it's premised under an overarching vision that supporting children, young children from birth to age 3 in particular, in receiving the supports that they need to grow up healthy, curious, happy, and ready to learn is kind of the overarching goal, and that really thinking about leverage points around pediatric primary care, because that's such an important period of time and time of frequent exposure, as well as really thinking about how parents are really an important part of that equation. That's sort of the broader vision and umbrella, but the particular piece that myself and my team have been looking at is really then thinking about how do you bring in that Medicaid and CHIP component to it, because there is such a ripe opportunity there. And we'll talk about now in just a bit about, kind of why Medicaid and CHIP can be that driver. What are those particular opportunities, and kind of thinking about like what's the proposition to states and what can the different opportunities be. So, as I think we've heard this stat now a couple of times around, really the importance of Medicaid and CHIP in terms of a coverage source, that half of all young children are covered by Medicaid and CHIP. As you go up into the higher age groups, it's still about 40% of the children in the U.S. are covered by Medicaid and CHIP. And with that coverage vehicle, it can really influence the way that care is delivered and the standards of care that we're adhering to and the different connections that can be made. Again, we know that the well-child visit is such a critical time, that there are frequent exposures and points of contact, that can be a good jumping off point for lots of different interventions that start from screening but really move towards connecting to community resources and really allowing for that kind of cohesive level of system coordination. And that Medicaid and CHIP both offer opportunities and the flexibility that is designed in those benefits and the different ways that states might be able to leverage that to allow for that. And I won't spend too much time on this piece, but clearly that the strategies that we're thinking about need to be thought about, including the family and including parents and caregivers, that we know that central to a child's healthy social and emotional development is really their parents' health and social and economic status and factors, and that 2-generational and family-centered strategies are very necessary and important. And again, Medicaid and CHIP can play an important role here. We've heard about coverage opportunities with coverage expansions, as well as strengthening the type of coverage that is available to pregnant women to really help to enhance that, but it's also maximizing those coverage opportunities for dyadic therapy and coverage under a child's Medicaid or CHIP coverage to allow for that. And building into those care guidelines that Medicaid and CHIP agencies issue to their providers, strengthened requirements around caring for children and addressing social and emotional health. But clearly a very important link in this conversation, in that there are tools under Medicaid and CHIP for that. So the good news that I am here to share is that there is really a lot of state interest. We've seen that really developing, that we've reached a moment in time where there is really that intensifying level of interest. And it's being driven from a few different ways. That once the brain science is really there to show that the evidence of early child development in that really critical time, that Medicaid, as these state agencies are really focused on thinking about, social determinants of health from that broader lens. Also, in thinking about value-based payment, there's a larger trend around, what are we paying for in our healthcare system, and are we really getting the most value and really helping to ensure that those delivery dollars are helping our children thrive. I mean, there's a lot of state interest in sort of linking kind of those conversations together. And then, unfortunately, our country is facing a very severe substance use and mental health crisis that's really driving a lot of focus around thinking sort of beyond the bounds of physical health, really thinking about behavioral health and those linkages between behavioral and physical health. And all of that sort of taken together, we've seen a lot of really ambitious states kind of trying to move forward now and thinking about, how can we be leveraging our healthcare system to really be advancing in these areas. And so what we have pulled together, and I'll try to save some time to talk about one strategy in detail, but it's really a family of 5 strategies. And there are 5 core strategies about how Medicaid and CHIP can be leveraged to really focus and enhance a focus on children's social and emotional development. And the way that that resource is pulled together is really intended to be an actionable resource that has the background research on the law and the regulations and policies, and really lines out, what are those implementation tools that a state needs, but also where a community organization or a provider who's really interested in these, this is a good way to open that conversation then with your state agency of, these are the tactical steps that would need to be taken, and here are also other states that have successfully undertaken these strategies and the models that they've used. And so it's a 60-page report, so I'm not going to go into that in intense detail, and that will be included in your links. But I did want to just share with you sort of the top levels of the 5 strategies, and then maybe drill down just on one of them very quickly, because there's been increasing state interest in this one in particular. But the types of things we're talking about Medicaid and CHIP being able to do is either directly through the state agency, or because the majority of states now rely on Medicaid managed care plans and CHIP managed care plans to deliver those benefits. It also includes thinking about requirements or opportunities in those managed care contracts to enhance the delivery of care for children. But the range of strategies include covering that kind of full range of screening and assessment and treatment services for a child and their parents, leveraging the different types of quality and performance improvement incentives that are inherent in the Medicaid and CHIP structure, but really thinking about that enhanced focus on social and emotional development. Different sorts of payment models and incentive models that might be able to be leveraged, again, kind of driving towards that state interest around value-based payment and focusing your dollars appropriately. There are also opportunities for Medicaid to be really supporting a team-based care approach, so moving beyond the traditional 4 walls of a doctor's office and moving towards thinking about care in the community and the different settings that might occur. And then finally, on the CHIP Health Services Initiative, which I highlight because it's something that we actually have recently spoken with a group of states about, and roundly, almost every one of them was interested in learning more and pursuing more, because it really is a special type of flexibility that's offered under federal law and gives states a good degree of flexibility to pursue different types of initiatives within the confines of the CHIP federal dollar. And some of the examples of things that states have been able to pursue in a CHIP HSI have been around providing enhanced services for school-based health centers. And I think the really interesting thing about the CHIP HSI is it needs to only be targeted to individuals or children who are low income, not necessarily individuals who are Medicaid or CHIP eligible, which is a little bit different than maybe some of the other strategies we're talking about with Medicaid and CHIP. But other ways that states have also been able to leverage CHIP HSI dollars have been around violence prevention programs and supporting really other community-based resources. So that's one in particular that I think we're going to see a lot more growing interest to, just because of the significant degree of flexibility it offers, and that there are opportunities for states to be able to really be leveraging federal dollars at an enhanced match, meaning they don't put up quite as much on the state side as they might under a traditional Medicaid program. So I know that was quite a lot to get through. I promise you all of the deep details are in our longer report, and hope that it provides you with a lot more kind of the tactical information. But again, happy to answer more questions, and definitely feel free to reach out.
Good afternoon, everyone. My name is Sarah Mathew, and in the interest of building strong relationships, I will tell you just a minute about myself. I am an early childhood educator. I spent the beginning of my career in classrooms with little people and loved going to work every single day because of the joy they brought me. Then I was actually walking my dog behind a hospital, And all these doctors we'd all walk dogs in the morning, and they were always like, I have all these free programs, and kids are at school all day, and I can't get them to let me in. And I said, did you ask them what they need? And suddenly I was a genius. And I was hired by a hospital, and my career took a total turn into health and wellness. And 7 years ago, I became the Director of Health and Wellness for the Colorado Department of Education. So, the big green button, got it. So this is my great state. It is a beautiful, beautiful place. It is a place that has long been considered one of the healthiest states to live in for physical health. But I can tell you that we are in the top 3 states for youth and adult suicide. And in my own son's school last week, a 9th child completed suicide in 3 years. It has far, far surpassed epidemic proportions in our state. And we at the Colorado Department of Education find it to be obviously one of our #1 priorities with what we are doing there. So there is a lot that I have to cover. Luckily, I'm from Philadelphia. I talk super fast. So school mental health in Colorado, I've been asked to talk about how we fund schools. And I feel very, very fortunate that our school has, our state has recognized the need for schools to be funded in this area. But keep in mind that we are 49th overall, lowest in education funding. So I'm quite fortunate to have the funding that I do have to address health in schools. The premise for a lot of the work that we do in Colorado was funded by our first large federal grant called Project Aware. If any of you are familiar with it, it stemmed from the Sandy Hook shootings. We are considered a model state for the funding. A lot of what we did was look at 3 distinct districts that had very distinct needs and ask them to help us build infrastructure and capacity to meet their students' needs for mental health. They all were very different. One was suburban, one was urban, one was rural. And we have some really great learnings, and we have actually a publication that will be out at the end of the month on what we learned from Project Aware. But essentially, the purpose of Project Aware was always to build infrastructure and capacity at the school level. And that has been the premise for much of the work we've done. The second largest, or the largest funding source we have in Colorado is actually our school health services program through Medicaid. Are any of you familiar with the school program for Medicaid? Schools actually get money from Medicaid for some of the work that they do. In our state, we have $43 million that comes in the door, which is significant funding for a state that has less than 1 million children in the public education system. $43 million comes in the door, and what we do with it is totally decided. It goes directly to schools. So there's no money going to the operational fund. There's no money going to the general fund. This money goes directly to the schools that participate in the program. It's built on a partnership with healthcare policy and financing. They work with districts to pull down these funds through IEP kids that have Medicaid billable services. So HICPUF works with districts on pulling the money down. What we do at the Department of Education is help them to use the funds strategically to meet the needs of their students. So we help them to make data-driven decision-makings and bring a group of community, parents, students, and school staff together to draw up a plan for how they're going to utilize their services. In our state, we have 178 school districts. We have 60 of them participating in that program. So that services over 86% of our students in the state. So as you can imagine, those other 128 districts have very, very small populations, and it actually becomes cost prohibitive for them to participate in the program. We are working extensively with them to pull their resources together and bring that more to their schools in the smaller districts. This is the biggest grant we have. This is the School Health Professionals Grant. We have, this is a grant that stemmed from our marijuana cash tax. You might have heard about those mountains that we had. They're nothing compared to marijuana. We now are considered experts in funding schools, and we do that through our Medicaid or our marijuana funds, which we are so, so fortunate to have a governor who looked at this and said, I want money to go to schools. So it started out with $2 million that was modeled after our Project Aware. So it funds school health professionals, counselors, psychologists, social workers, and nurses. It funds their positions, and then it gives them resources and money to do professional development and technical assistance to staff, families, and schools to meet their mental health needs. Through that work, all of those districts that we have 66 different funded districts right now, 66 districts have come to us and said substance use is not our primary goal. Substance use education is important, but it's a symptom of a larger problem. So what our districts are doing is focusing a lot on building infrastructure and capacity for their schools to meet all the mental health needs of their students. So that really has risen to the top to be suicide education, trauma-informed care, and social emotional learning. The early childhood educator in me says, finally, we are talking about social emotional learning, which is what we've been doing in early childhood all along, right? But now we're realizing that kids don't fall off a cliff when they're 8 years old and no longer need those services. So we are now really, really pleased that that grant has gone from $2 million to $15 million with a trajectory of getting more into our state. We fund almost 300 FTE across our state through that grant. We recently passed a law. A lot of what I do is in statute, and I'm so fortunate. But the Social Emotional Health Act that just passed recently will give funds from the marijuana cash tax funds to elementary schools specifically. And what that will do will get them one school health professional per grade that will follow that cohort of students through elementary grades. We all know the greatest risk and protective factor is a strong relationship with a trusted adult and having really strong services that are provided, but also consistency across those services. So this is a new grant. It's actually being competed right now. We don't know how many schools will actually apply and receive this grant, but the goal of it is to simply provide safe, supportive, and positive school cultures and climates for schools. But this is so exciting. It also requires schools to have a social worker that will look at some of the physical health contributors like food access, food insecurity, helping them get health insurance. Cool, hey? We're now talking about physical health and mental health in the same place, which is just crazy, I know. We have bullying prevention grants that are funded through this funding as well. This is $2 million that has been funded, and the outcomes for this program have been tremendous. Although I will add this, we have done tremendous work to align our data systems. We have a wonderful survey that is surveying students. We had 80,000 students respond to our Healthy Kids Colorado survey in 2017, and most of them did not identify bullying as their primary need for sadness or suicidal thoughts. We hear continually from schools that it's more academic pressure and social pressure. And so although we really value the work that this grant is doing, we are not offering it up as the answer to suicide. That linkage scares us. We don't want that to be seen as what the cause is. Sustainability of everything, we believe, lives in our standards. I've had one foot in education, one foot in public health for about the last 20 years. And what I know is that if it isn't in your standards in a school, you aren't speaking your language, you aren't going to be able to get to them. So I have been a champion for making sure that social emotional learning is cross-cutting across our standards. We have them K to 13 or K to 12, but we also now are integrating them into other subjects in school grades. So we're integrating social emotional learning into science, math, and what's the other one? Language arts. So here's my contact information. I have 26 seconds. I did skip a slide, so I'll just go back and say that it actually was a really valuable one. But from the Department of Education, we hear continuously about school climate and culture and trying to get that aligned with accountability systems and social emotional learning. We are at the forefront of that. In fact, I'm a fellow with the CCSSO, which is Chief School Officers and Aspen Institute. We have identified social, emotional, and academic learning and bringing those two together so that when we're working in a school, we're not asking them to have a similar framework yet different. We want to bring those things together and have social, emotional, and academic learning all together. Zero. Yeah.
Great. Thank you so much to our panelists. I'll go ahead and kick us off with a question, but please, if folks in the audience have them, this is the time to grab a mic and ask them as well. So that was a tremendous amount of incredible information for everybody to digest. I'm wondering if you could each just kind of based on those opportunities that you shared, just think about if you were to recommend to the group, recognizing that we have a mix of folks who are on the ground in schools, some are with advocacy groups, national groups. What are some of the first steps that you might recommend schools or school districts or even state leaders take to leverage some of the opportunities that you highlighted today?
I would say, the Marijuana Cash Tax Fund is a new funding source that's coming up, and we do have a lot of learnings from that money, but we hear continuously from many states that are using those funds to broaden mental health services across the spectrum. But the other thing that we in our state are very fortunate is that those Medicaid dollars that I said go directly to schools, we have a law that was passed that says that they go to the health of all children. It's time for us not to be concentrated on the most severe. It's time for us to really be looking across the spectrum. And so I get contacted frequently by other states that are asking me about that law. And since we're talking about policy here, policy and laws come together. But I would say that's been one of the biggest wins in our state is that money can go to the health of all children, which means prevention.
Yeah. So I think in terms of, there are lots of opportunities. I hope that was a takeaway around Medicaid and CHIP and ways in which you could really be enhancing social and emotional development. It gets kind of technical, kind of quick, but I think the takeaway would be, one, to identify what it is what intervention are you seeking to introduce. And I think the way that you'd want to think about that is then looking at, there are a number of these different opportunities that could be driven through care standards, could be driven through care teams that are available, that could be driven through different initiatives, and really understanding, where your state is in that mix. Have they pursued all the flexibilities that might be available under Medicaid and CHIP currently? How far have they gone in terms of the standards that they're setting for managed care plans around care management and the level of attention paid to trauma-informed care and how that really influences the philosophy of care delivery? I think it is getting your arms around sort of what's happening in your state too, and it might be digging into state policy documents or better understanding of the different kind of areas that they pursued. But I think that's where we were really, in pulling together the blueprint that I referenced, really trying to think about, what are those first steps? And there are a set of implementation steps that we outline for each strategy to give folks that kind of starting point of what document do you need to be looking to in your state where this might show if they've pursued this policy or not? Or what analysis do you need to start with in terms of understanding, for instance, the CHIP HSI opportunity I featured? One of the first steps is really state financial analysis to understand the availability of funds that a state may have to pursue this. And the good news is that a lot of states do have those funds available, but that is a critical first step. So it is sort of different for every type of strategy, but hopefully that gives you kind of a starting point in looking kind of more concretely.
Yeah, I think I would echo everything that's been said. I think prevention is absolutely the space to be thinking about and doing work, and it's really about the cross-sector, cross-agency collaboration and opportunities, and where can you leverage interest and enthusiasm and work that's happening to do that work. And so an example is right now, states are implementing the Family First Prevention Services Act, which opens up Title IV to not true prevention, but prevention services to keep kids at risk of entering into foster care from getting into foster care, and it opens up the funding stream, the entitlement funding stream for things like in-home prevention services, substance use treatment, parent skills-based training. So a lot of opportunities to really think about not just what you can do with those dollars and that sort of narrow dollars in terms of prevention, but how do you build out this prevention continuum that can really support families and children across your systems and sort of moving upstream. So using those dollars where you have them, but then really pushing the rest of the dollars further upstream. And I think people need to be at the table. It's not just child welfare agencies that are doing this work, that you have to have your health partners, your early childhood partners, your domestic violence partners, public health. So I think it's really an opportunity and moment to think about that broader prevention continuum and meeting the needs of all kids and families. So finding those opportunities and that interest to really leverage an existing opportunity to bring everybody to the table.
That's great. Thank you. We have questions from the audience. Elizabeth? Yes.
Is it on? I'm not tall enough for this mic, so I guess I'll just do my question is actually specifically for you, Sarah, around the funding streams that are tied to FTE as it relates to school mental health providers. So we have similar legislation in Wisconsin, but we are still running up against recruitment and retention issues in those particular domains and some special education domains as well. And I was kind of curious from your Department of Ed perspective, if you have any ideas or key strategies around supporting both recruitment and retention so that as the dollars flow, there are people there to receive them.
Yes. Actually, our law that actually gave us that grant 5 years ago when we first legalized marijuana has changed every single year. And one of them has been to contract services out because of the shortage of teachers and qualified individuals. But what we have encouraged schools to do is really look at their data and identify what their need is and then look for the position that would most meet their needs. And in doing that, we have found that there is a shortage. I will tell you that this grant, because it's giving money to schools, they've been able to up salaries. Yeah. So they couldn't compete with the local hospital to get a nurse or a counselor or a psychologist, but they can definitely have a more competitive salary and then be able to also contract with community partners for that. We also have changed the licensure that it doesn't have to be just a state licensed by the Department of Ed. DORA licensure will count. And that just was a change that happened 2 years ago. And then this past year, the contracting law passed. So we have seen districts get very creative around that issue. But at the same time, our administration, our Department of Education, our commissioner has been working closely. We are a state where a lot of folks are moving there. Yeah. So there's a lot of people coming in. And so we're really looking at, even outside of our state, connecting with institutions of higher ed, that just to make sure that they're aware that we have this grant and that there are positions available. So that's one strategy.
Hi, Kathleen Sidlecki with Kaiser Permanente. First of all, kudos to our speakers, who I feel like this whole day I've been listening to an audiobook on 1.5 speed. There's been so much great content. I want to go back and listen to it at 1.0 speed. So, Alice, I was really interested in one of your slides talking about the kind of next generation efforts on value-based payment, because I think that's one of the challenges that we look at. How can we make the case for investments in these interventions when we may not see something for, 20, 30, multi-generational? So just interested in...
I think that is definitely a central issue around thinking about value-based payment in a cross-sectoral way. I think it does require that mind shift. And someone from New York said to me recently, and we all said we love the way that this was phrased, but it's not a return on value, it's a return on our future that we really need to be thinking about in terms of value. And the savings may not accrue to the healthcare system. It's going to accrue to education. It will accrue to other systems that these children touch. And we need to be broadening our thinking to think about that sort of framework rather than the silos that we've been operating in. And I think it really does require that kind of shift in the mental model of how we think about, value-based payment and working through those advances. But there are states that are forging ahead. Pediatrics has not generally been an area that there's been a lot of value-based payment focus because the costs aren't that significant when you're thinking about that in terms of other populations and the spend there, but what the long-lasting impacts look like. And we're really seeing kind of those sorts of innovations now being moved forward where we're thinking about value-based payment in a pediatric context. What does that mean in terms of primary care and prevention? And we need to make the broader case. And states like New York, states like Oregon are all sort of moving in that direction and thinking about developing sort of a broader lens around that and broader metrics that really hold multiple kind of systems accountable.
That's great.
I want to just build on that point, and then Sarah touched on this also. I think as we're thinking, we've heard a lot about cross-sector collaboration over the whole day, and I think a key challenge that we run into in this work when we're sitting at the intersection of health and education is that they're speaking different languages. And I really, when Sarah shared, that the hospital was struggling to figure out how to work with the school, we hear that so often, that the resources are there, but often it's just figuring out how the two can communicate with each other and really make the case for how they both stand to benefit from partnerships. So I'm just wondering, kind of building on Alice, what you said about, that it's an investment in the future, Sarah, what you ended with when talking about accountability. If there are any lessons that you've learned from your work that really kind of lift up those lessons learned about how to build those cross-sector collaborations and what some of those key messages are that might resonate with folks in other sectors to build those partnerships between education and health, or even, broader other sectors that need to come together around this work.
Sure. So I really was fortunate when I came to the Department of Education. There already was really strong cross-sector collaborations going on, but we actually, in Colorado, I have to say, legalizing marijuana made us all play together. It sounds crazy, but our governor came to us and said, okay, what do you guys need? What do you guys want? The last thing I want is to legalize marijuana and have youth use go up. That is the last thing I want. And so what we did was essentially all look at each other and say, what is it that you can do that I can't do? And I think one of the biggest pieces that we work with schools on is being willing to make some sacrifices, because we can't all own every piece of everything. First of all, none of us are effective that way. But the other piece is then we just end up working at odds with each other. So really, we had really strong leadership, our commissioner, but also with the other state agencies, all came together and said, okay, for early intervention and treatment, that's obviously CDHS that needs to be doing that. And then as the discussion and as the funding goes on, we look more globally at mental health and realize that schools are where kids live 8 hours a day, but they're not, doesn't mean we can do everything in a school day. We can't even do enough to just do academics in a school day. So to continue to always come to their door and say, but you guys are there, that's where it should happen, it doesn't work. And so what we found was that if we could talk to schools and say, if you build a strong relationship with your local public health, they can be doing some of your family education. They can be doing some of the education in the classroom even, and work with your teachers. And that's one of those things that stemmed from the shortage of professionals in our state, but it actually really made schools more collaborative with their local community partners. So one of the things I always say when I'm asked this question, I'm asked this a lot on why we have such strong state level collaboration, is because some of us were really willing to give up things. We didn't try and keep doing the whole pie. And so in owning the piece that you can do and that you're best at, and then working with others to help them, you kind of are like a puzzle that comes all together.
I don't know, Alice or Shadi?
No, it's great.
Hi, this was so much great information. There's so many great financing opportunities for students, and I know that's the focus of today is children, but have there been any examples where you could identify longer-term sustainable financing for educators and adults for their own well-being versus, just them as a conduit to students? But has there been, anything that Colorado's done creatively with the marijuana funds that have been aimed at educators, either K through 12 or even, caregivers in the earlier child care settings that have been funding for them?
So in Colorado, we have the Colorado Health Foundation, and they've done a lot of work with schools, funding them directly. We use the whole school, whole community, whole child model, and I hate to call that out in particular because it's always been confined to CDC and being a health model, and I'm always trying to make people speak the language of schools, not just health, but that really includes staff wellness. And when we unfortunately started to fund schools to do the school health professional grant, we heard over and over how traumatized the staff were when these youth were completing suicide, and where, my son goes to a school that had a school shooting in the school 4 years ago. These schools, their whole structure has been affected by this. And so that money can go to staff wellness. And really what we do is really bring that trauma-informed approach. You know, there isn't a trauma model out there that really doesn't get to addressing parents and staff. So that's evidence-based. So we really try and push evidence-based practices that include those pieces. But we hear over and over and over again that school staff right now are so overwhelmed. These folks are doing the best they can, and they're still, you know, I couldn't be a teacher again. I really couldn't. And so what we're doing is making sure that our money is holistically going to the school and looking at the school as a whole and not pulling out staff as separate from school, you know, parents. They can do all of that. They can do parents, staff, and school and youth. So our program goes to all.
I don't know, Shadi or Alice, do you have any thoughts?
I think not quite from a Medicaid or CHIP perspective quite yet.
Yeah, great. Yeah.
I have a question. I don't know if we've got time.
We've got time. Our time went up.
Oh,
It did.
so it's great.
I know.
Pretty exciting. So it's great to hear about the federal drawdown of Medicaid dollars and more effective ways to do that, and some state level strategies that are specific to Colorado. I'm interested, have you experienced any early or know of any sort of early childhood efforts to leverage federal dollars on the education side to support the health education nexus, especially around social emotional health and well-being? Or do you think the opportunity is primarily through Medicaid on the federal level in particular?
I mean, my focus has been primarily on the healthcare side, so I don't know if you or Alex can talk a little bit more on the school side.
Yeah, my primary focus has been on the Medicaid and CHIP financing dynamics, and I think where you see the kind of intersection with education is typically with school-based health centers and school-based funding for children on IDEA. But I was actually thinking on like the other sorts of approaches and coordination with federal dollars would be from Family First, for instance.
Family First, early intervention.
Right, and thinking about how to coordinate those different funding streams. I don't know if Sarah or Alex, you have other kind of perspective from the education side.
Right. I know, and our focus is more on the K-12 space, but I know I mentioned the Every Student Succeeds Act earlier, and there is a provision within that actually does designate funding to really ensuring a smooth transition between early education and then the K-12 space. And so ensuring continuity of services that kids might be receiving in early childhood spaces. And I think we're still trying to understand exactly how those dollars are being utilized, but I think that's something that is particularly relevant to the conversations that we're having today, just that there is kind of that investment from what is traditionally seen as this K-12 piece of legislation in the early childhood space in order to ensure that continuity of care. And then I will just also, on the Medicaid piece that Sarah spoke about, there's a new opportunity for states to really look at expanding their ability to let school districts claim for a lot of services delivered in schools. Traditionally, districts have only been able to bill for Medicaid services included in students' individualized education programs, and now they can bill, states can give districts the ability to bill for any Medicaid-eligible service delivered to a Medicaid-enrolled student, which has huge implications in terms of mental health services. And that also would apply to, in the early ed space, any early education program being run by a school district. And so that's something that we're also looking at, is how to draw down those Medicaid dollars in publicly run early education programs. Great. I think we're over.
I can do one more.
Oh, one more.
One more or no?
Okay. Quick.
Well, it might be quick. So I guess for me, thinking about the mental health providers that are coming to the schools, at least in Minnesota, the Medicaid rate for behavioral health hasn't gone up in about 10 years.
Yeah.
And so we're finding the same workforce issues because salaries can't go up, people aren't going into the field, all these things. So my wondering is, with, moving to a value-based payment, is that going to bring more dollars in, or is it just going to be a new sexy way to underfund children's mental health.
Sexy right on.
Right? I'm sorry. I'm just trying to be real about.
I mean, it is.
Yeah.
So.
Do you want to take
Well,
it first?
I think it depends on how you structure it. And value-based payment comes in a lot of different flavors, but there are ways to help to provide capacity building dollars to providers as an early stage of value-based payment, so that we're really trying to help to support practices, ensure that the care models are being adhered to, that they have the resources to do that and build that infrastructure, so that then they're able to really move up that value-based payment ladder in terms of complexity of arrangements, and really then shifting to not just incentives but taking on risk. But you do need to have that infrastructure in place. I think that is definitely a critical component for a provider in order to be successful under a VBP model.
I've had a lot of students calling me like wanting to go into the mental health field. They're like, well, there's so much need. I'm like, yeah, but there's not a lot of money.
Well, no, and this issue of rates has come up in other states that we've worked with, and it is a huge barrier. So some states are really rethinking the whole sort of continuum, and how do you build out like your capacity, your rate to improve the quality and the capacity of your workforce, and kind of doing a redesign of their behavioral health systems. And so I think it's part of how you think about restructuring and redesign.
Thank you. With that, I want to thank our panelists. Thank you, Alex. Thank you. It was awesome. Thank you.